Boy, if I understood that electricity stuff, I could do that.
Yeah, there was some noise there I didn't understand on the screen.
Yeah, I think I'd like to go to room 1.
All right, what do you got? What do you have?
Let me introduce this is the HonorHealth team, and ask Andrew to maybe present the case and go from there.
All right, go ahead and pull the case up. I'm going to introduce the team real quick. We got a great team here today. We got Dr. Baumler on anesthesia in the back here. We got Dr. Burke on TEE, Dr. Riley, Dr. Reisman. We got Alfredo and Sophia, and then Melissa in the back here. If you want to pull up the slides, we're going to go ahead and get started because we're running a little ahead here. So this is a 71-year-old woman who presented to us initially back in 2017 with severe MR and TR, underwent surgical ring repair of both of those valves. The mitral was a 30-millimeter Edwards IMR ring. You see the rest of her medical history here. She's a pretty complex prior right-sided CVA, pretty significant ortho injury with cervical spinal stenosis. She did well for a couple of years after the surgery. In 2021, had recurrent recurrence of that mitral. So ultimately, they ended up putting successfully a 26 S3 in. Fast forward a couple more years, 2024, he started to develop symptoms and is now coming back again with severe MR. Next slide. So we were asked, could we do another valve inside that prior sapien, inside the prior ring? And so we went ahead and CT and see here the measurements, area 447. We got an AP diameter that, at least on the CT, measures about 20. So somewhere between a 23 and a 26 measurement here. Next slide. You see the aortomitral angle is favorable, 137. Next slide. Very favorable neo-LVOT of 447. Next slide. And it's just another measurement there. Oh, Dr. Riley, I'm going to ask a comment real briefly on this IMR ring and pros and cons and why it was used.
Yeah, so originally this was done in 2017. This was a pre-coap patient, so it was a EF of about 25% at the time with dilated mitral and tricuspid annulus. So it was a deputized ring annuloplasty. The IMR is a rigid ring for ischemic functional MR. It's very D-shaped and has a dip in the P2, P3 area to help bring that up for the functional MR patients. Post-procedure, initially in 2017, no MR and no gradient. About 2 years later, there was moderate, and 4 years later, severe MR. So very kind of predictable. What we would know today is we probably would have treated this patient with clip instead of with downsized annuloplasty. But the ring is very rigid and not modifiable.
Yeah, so just to maybe hand it over to the panel, but essentially we have a very rigid ring. I think in some ways they were very fortunate to get a good result at the original procedure. Felt to be a high-risk patient for another procedure. I don't think anybody thinks this is the ideal situation for managing this problem, but it's at this point from the clinical history, it seems like really one of the only one that is left for her at this particular junction. So we've given it a lot of thought in terms of how to manage it. There's previously a 26 in there, so we elected to go with a 23. We know that ring is not going to give, and so the final decisions are really with the 23, how to position it. We thought we use the ventricular side of the 26 and go a little atrial to that. The plan being that the 26 is probably about 20 in length, fully expanded. It's probably a little bit shorter because it's probably not fully expanded. And the 23 is 18, so we want to get that atrial flange well opposed, obviously, as well. From a TE perspective, maybe I'll hand it over to Dr. Burke and just make a couple of final comments, and then maybe let the panel make some comments as well. If you guys want to start going up, it's fine.
I'll start you go straight AP.
Yeah, so baseline here, we have significant mitral regurgitation. We end up with the reversal of flow in the right superior pulmonary vein, so it's a somewhat eccentric jet here. Looking at it, we definitely have, as Dr. Reisman was saying, sort of a D shape to the entire complex. And we can again see that we've got significant mitral regurgitation. The mean gradient was 7 millimeters mercury. At rest here at 75 beats per minute.
Are you out of the sheath with the, just make sure you're out of the sheath with
Come further, Josh. Yep.
So what was the mechanism of the MR here? Is it a fixed leaflet?
Actually, this is probably more pinwheeling than anything else, and there's been structural deterioration of the 26S3, and as a result, there's been a lot of regurgitation there. It never really rounded out very well, which I think was in part related to just the 26 being technically the right size as far as valve app and everything else, but not being able to get the same AP as opposed to lateral dimensions there on the valve.
So I'm going to call Adam Greenbaum. Why don't you give us your take and how would you handle it?
I'm having trouble here. Say that again?
Yeah, just your comments on the case and how you set this up.
Sure. So I think 23 is the right size here. The AP diameter on that ring originally is about 19, so you're never going to get a 26 to fully open here. There's no risk of LVOT obstruction, right, because the patient's alive now, and the anterior leaflet, assuming it wasn't modified, is already draping around the valve. So the neo-LVOT measurement's not all that important, right? You're going inside a valve that's already covered. So I think 23 is the right size, and I would try and make it as circular as possible, so you be prepared to put in a true balloon. And
so there's nothing you can do with electrosurgery? I thought you'd say you would take some catheter and cut it out and split it in half. And
well, if you didn't prepare for that with the first one, there's nothing to do now, right?
So we're just going to have to, it's going to be oblique. That's okay. That's fine. I'll be okay.
I think one of the key things is they decided to go with the smaller valve. And, you know, I'd much rather overexpand a smaller valve than underexpand a 26. That would be, and sometimes on these, if I'm doing balloon inside a balloon, I'll go and pre-balloon. This is a Carpenter McCarthy Adams ring. They're designed to fix the annulus and systole, and they don't move at all. It's a problem.
You could take this part, and clocking it is going to bring you atrial. Counterclocking is bringing you ventricle. Pushing, obviously, no. Okay, we're just setting up the deployment here. We're going to be, I think this is obviously off axis a bit. We don't have much parallax on the valve itself, so we're just going to do a slow inflation here.
Yeah. Adam, just a couple comments about trying to get this thing coaxial. Any tricks? Hey, Adam.
Pull your pusher bar
no reason to pay.
Push it on the wire.
Try it.
Try it. You can kind of push the wire. Yeah.
Just go slow.
Either go counterclockwise.
So I would imagine that if you use a smaller valve, there's a better chance of full circularity this time, but there would be potentially a risk of PVL. Is there a role to sew something around this to reduce the risk of PVL?
Yeah. Okay.
So if I'm operating
PVL here
on
is
it,
not
then
going to be
the
because
answer
of
is
the
you can't do it.
PVL is going to be
And
because
PVL is not going to be a problem. This is going to round all the way out.
But the average here was around 24, so if you add some extra in this and try and push this 23 to 24, I think you're going to get a good seal.
Okay. So pacer on? Is on?
You got to accept the gradient you're going to get with a 23, but you'll have 23 with no MR.
That's perfect.
Nice slow inflation here.
Perfect. Push forward. Push a little forward. Good. Yeah. Keep pushing. Yeah. Got 1,000, 2 1,000, 3 1,000, 4 1,000. Time and down. And pacer off.
Pacer off.
That was all of the +3.
Okay, walk it out, walk it back.
So
Just don't keep wire down.
make a comment about the technique there, which is very underappreciated. That they showed their expertise, how they modify the deployment. It was a slow deployment, but also it was a little canted. And Mark said push the valve, and there was an aggressive push to actually make it coaxial. That's something that it's hard to understand and teach unless you have experience, and less experienced centers have difficulty dealing with that. In fact, and then that they cant the valve and they end up having PVLs and other issues.
So the issue here also is, so clockwise, we know we'll bring in more atrial. We played with that a little bit. I tried that to just take it up a little bit. Counterclockwise, we'll bring the valve more ventricular. And then obviously just the push and pull. At the point I was asking him to push forward, that was almost just so it wouldn't come back a little bit. It's hard when it's sort of a little bit inflated like that. So here, we could go through it here. So here, We could have pushed up a little bit on the catheter just to get it more coaxial. But as you can see, it's walking up a little on its own, and then we look good there. So I think we did okay. And we could see we walked it out. Maybe Dr. Berg, you could give us an update where we're at.
So we got some wire-related regurgitation right now. Quickly get a gradient across the valve, see what we've got. Again, it's going to be affected by the fact that we've got the valve splinted. Looks like we've got less than the baseline 7, just to eyeball it. So our new gradient is 4, so
great.
looking good.
All right, I think if that's what it is, I think that would be a real win. We were thinking about going with a true balloon, a 23 or 24, but if we have this gradient, I think that would be acceptable with no MR or minimal MR.
Where do you think that MR is
The question
coming
is,
from?
where's that leak coming from?
Yeah, I'm seeing it. It looks like it's intravalvular, right?
That does look like that could be intravalvular there.
Yeah, maybe.
Because it looks like our piezo formation is inside here. I put a pointer on there. I'll zoom that up so you can see it a little bit better.
Maybe
So it looks
switch
like we're
out the
internal
wire for
here.
a pigtail.
Yeah,
It'll interfere with those leaflet flaps.
Yeah, well, the only other thing we could do is we could hit it one more time just to make sure we're done with this balloon. If that's in the valve a little bit, maybe between the two valves, right?
Right. What's there on the
That might be actually paravalvular there.
Yeah, between the two, right?
Yep.
Hit it one more time.
Well,
Yeah, let's hit it one more time with this. I don't think it'll be a big
you could
problem.
also,
just to make sure.
you could go LEO, if you
There's
can
no
get
flex
to
on.
LEO caudal with the camera, you can see if there's a gap between the two, you know?
Yeah, we could do that.
Probably,
Let me hit this
I
first,
don't know.
Adam, and then we could take a quick peek.
50-20.
All right, so let's pace. Push away. What? Stop. Just bring the pusher back a little bit more.
It could be between the original and the ring now that you've got the central MR, you know?
Bring it back.
That's a big thing. They need to figure that out.
there.
You think it's between the ring and the valve?
Could be because
All right.
Okay.
Pacer back on.
Pacer on. Capture. Going up. 1, 2, 3, 4, 5. We gave it all and down. And pacer off.
you know,
All right, let's walk this out. I think we're done with this, and then we'll see what we got.
I think it is important to figure out if that leak is central between the two transcatheter valves or actually between the original valve and the ring, because sometimes when you eliminate the central MR, you unmask, you know, the paravalvular leak, because now there's...
That's looking more central now with what we've got left.
Take a big down.
So we can switch it out. We can switch the wire out for Piggy. Let me see what we got. Pigtail, please.
This looks significantly better with that post-dilation.
All right, good.
Does everybody on the panel, while they're making the switch, does everyone still pace for mitrals? You know, I stopped pacing a while ago. I mean, if you need to pace, it's because you think you need to stabilize the annulus on your screen. But in actuality, what I was finding was the rapid pace was freezing me in systole, and in some people, there wasn't enough room for the balloon in the ventricle, and it was creating canting. And actually, when I just let the patient stay in diastole, I was getting better coaxiality with the valve, particularly for valve and ring and stuff like that. So I stopped pacing for the mitrals. Try it. You might like it.
Adam, now you tell me.
Yeah.
All right. That looks better, right?
That looks great.
That's looking significantly better.
Sure. All of it wasn't due to the wire.
You want to roll around, just make sure we're not missing
The
anything?
original paravalvular, that little. You see it there?
Not much there now. I don't see anything.
Not much to write home about, guys.
Yeah, I'm not sure how much was due to that second balloon inflation, and it was all due to the wire to begin with. But anyway, it looks great now.
All right, we'll let you guys go next door to look at the appendage. But thanks for indulging us. It's a tricky case. I'm glad we were able to give this woman hopefully some benefit for a couple of years and maybe longer. Once we pull it, we'll keep everything in the atrium and just make sure that it looks as good as we want and the gradient are as good. And if not, we'll come back if we decide to use a true balloon to further dilate it. But thank you, everybody.